10 steps of vaginal hysterectomy, starting from the anesthesia, local anesthesia infiltrated around the cervix, front and back, not laterally. Incision, that is, you give incision. First of all, you will hold the cervix. How you will hold the cervix? You will hold the cervix, anterior and the posterior lip. Anterior lip and the posterior lip of the cervix, and you give the with the valsellum forceps, and you give a circumferential incision. Circumferential incision in this manner. And where you give, that is 5 mm from the external os. And the vaginal walls which will be here, are separated. Then the second step is the bladder dissection, that is detaching bladder from the uterus. Detaching the bladder from the uterus. The anterior vaginal wall was detached from the urinary bladder. Anterior vaginal wall detached from the urinary bladder beyond to the appearance of the anterior vaginal sulcus. The bladder is dissected off the cervix, that is, it's pushed up and reflected upwards, opening of the anterior peritoneum, that is, which we call anterior colpotomy. That is opening of the anterior peritoneum. At that stage is not necessary and not recommended, because it disturbs the dynamic of the operation and interrupts its continuity. So what you do is just the bladder dissection. Then opening the posterior peritoneum, that is the pouch of Douglas. The scissors are then introduced into the Douglas cavity, and holding each blade with one hand, pulled out open so that the back sides of the blades exposes the insertion of the uterosacral ligament, and the pouch of Douglas is open. You have to do dissection in such a way that the posterior peritoneum is open and the pouch of Douglas is exposed, and you have to expose the uterosacral ligaments. Then you do the dissection of the lower uterus. What is the importance of the uterus? That the uterosacral ligaments are lying here. So dissection of the lower part of the uterus, the uterosacral ligaments are clamped, cut and ligated. Cutting, then what you do, that is, after these uterosacral ligament, you come to the uterine pedicles, that is cutting and ligating the uterine arteries. Both uterine arteries are clamped, cut and ligated. Then opening of the anterior peritoneum. After both the uterine arteries have been cut and ligated, the uterus is pulled down and two fingers are introduced behind the fundus to lift the anterior peritoneum, which can be opened under vision with scissors. And then you do the morcellation. Right? And then you do the morcellation of the uterus, which is safe and facilitates removal of the large uterus. Then you do the dissection of the upper part of the uterus. What you do is dissection of the upper part of the uterus. What is the importance of upper part of uterus? That upper part of the uterus, in upper part of the uterus, there are, for example, this is the upper part, there are round ligament lying and the tubo-ovarian, because tubes are attached, so tubo-ovarian ligaments are also lying here. So the round and the tubo-ovarian ligaments and the blood vessels are clamped and cut and ligated. The uterus and the cervix are removed. If the hysterectomy will be done along with salpingo-oophorectomy, then you also have to take the infundibulopelvic ligament. That should also be cut. Here there is a precaution that to prevent post-operative bleeding, we usually do the double ligation of the infundibulopelvic ligament. That is necessary in all gynecological surgery. Then what you do, you deliver the uterus and the cervix, that is you remove it. Then if there is enterocele, for example, you are also encountering with enterocele, then it has to be prevented or repaired, and before continuing the operation you have to deal with it. After that you will do the reconstruction of the pelvic floor, that is the left and the right uterosacral ligament with the paracervical tissue as well as the as well as the ovarian ligaments are ligated to each other. Anterior and posterior repair done at this stage. Then closing of the vaginal wall, that is the vaginal wall is sutured continuously to ensure hemostasis. In closing of the vaginal wall, we include uterosacral ligament in repair of the vaginal wall to prevent the wall prolapse.